Dear colleagues, ladies and gentlemen, welcome to the view from the Thoraxcenter for Radcliffe Cardiology. This is the preview of the 2024 ESC meeting. My name is Nicolas from Mieghem, and as always, it is my great pleasure to introduce to you my good friend and colleague Joost, Daemen, and together we will start reviewing the ESC meeting. There are quite some interesting trials upcoming, Joost.
Absolutely. So there are some trials that we want to discuss. Perhaps not that many blockbusters as we've seen last year, at least in the interventional space. But at least there are some trials that caught our attention and I think are worthwhile discussing.
Yeah, multiple studies were long overdue, if you will. One of them is the REC-CAGEFREE I randomized controlled study. This was a trial that originally started in 2015, Multicentric initiative in Europe, and Stefan Anker is now going to present for the first time the results of this study. 505 patients will be or should be included in the trial, and patients will be randomized to MitraClip on top of standard of care versus standard of care. Obviously, this is a trial focusing on patients with heart failure and secondary MR. You might be familiar with the COAPT trial and the MITRA-FR trial. Those two trials generated more or less different results, if you will, and the interpretation of both trials was different because COAPT was considered to be a positive study in favor of TEER for secondary MR and heart failure, whereas MITRA-FR was neutral and some even say a negative trial. Now the question is, what is REC-CAGEFREE going to be? Is it going to be positive or negative? At least the primary endpoint is similar to COAPT, so it's a composite of recurrent heart failure hospitalizations and cardiovascular mortality at 24 months. But they also look at total heart failure hospitalizations at 2 years and a change in KCCQ in quality of life at 1 year. For me, this is going to be an important study. It's not going to be a game changer, but it might be good to have another positive trial for the space of TAVR and secondary MR.
Yeah, I totally agree. I think on the one hand, it's a trial that has the potential to be the second positive trial supporting the use of TEER in the mitral space. Conversely, it's a German trial. It's somewhat smaller. It's perhaps a trial with not that much scrutiny as you will, as for instance was in place in COAPT. So I'm not sure what the trial will show, but it will definitely generate discussion.
Well, it's not just Germany, it's really throughout Europe, multiple countries in Europe. But I think one of the limitations is the time window of study enrollment. So the study started in 2015. We're now 2024, so I think the results can go either way.
Yeah, we'll see.
MATTERHORN, that's another trial that started already in 2015. This trial is comparing surgery with MitraClip in patients with symptomatic secondary mitral regurgitation at high surgical risk. It is, for me, unclear whether this is a single center randomized controlled study or a multi-center study. Fair to say that the core of the study is Köln in Germany, and the aim was to enroll 210 patients. The primary endpoint is a composite of death, rehospitalization for heart failure, re-intervention, and assist device implantation and stroke at 12 months. This is a little bit of a different study. It might be more reflecting the EVEREST-2 randomized controlled study back in the day. So that was a study in 2009 where they compared mitral or MitraClip versus surgery, predominantly in patients with primary MR. This study is exclusively focusing on secondary MR. So it's a little bit different, but I think the fact that we're now talking about patients at high operative risk, that might be an interesting feature of this trial.
High operative risk, but operable.
But operable, but still, if you are at high operative risk, the price of the surgery
can be significant.
Can be significant.
Absolutely.
And might be a driver of the endpoint. So this is an interesting study.
Yeah, I agree, and a study that I think has somewhat more likelihood to become positive. But let's see.
Yeah. And then
TRI-FR.
Yeah. So also another trial in the tricuspid space. We have seen a lot of attention in tricuspid regurgitation in the last couple of years. We also have already one randomized controlled study, the TRILUMINATE, that was presented in 2023. Mixed results, mixed reactions to that trial. So a follow-up study or a new study on patients with secondary tricuspid regurgitation was definitely worthwhile. And this is where this French study comes in. Patients, up to 300 patients with severe TR, confirmed by an echo core lab and also confirmed by a screening committee, will be randomized 1-to-1 to either TriClip on top of standard of care or standard of care. The primary endpoint is a composite endpoint that they deem to be the Milton-Packer Clinical Composite Score, which is basically an integration of symptoms, New York Heart Class, quality of life, but also major cardiovascular events. And then either there are three categories, either the patient improved or worsened or everything remained unchanged. So an interesting study design, and I'm looking forward to a positive trial result here.
I hope so. I hope so.
Yeah, but okay, enough of the structural for now. Let's move to the coronary space.
Yeah, the coronary space, but still a little bit of surgery, is the SweetGraft trial. So SweetGraft is a multicentric randomized controlled trial that will be presented by Stefan James. And it was a trial actually designed to investigate if vein grafts harvested and implemented with the no-touch technique are superior to conventionally harvested vein grafts with respect to medium-term graft patency. So as you know, harvesting the saphenous vein graft with a pedicle of surrounding tissue and without graft distension is called the so-called non-touch technique. It has been shown in the past that this technique may have advantages in terms of graft patency, in a sense that it significantly improves patency as compared to conventional techniques at the short to medium term. This trial will randomize 900 patients with the primary endpoint being graft patency as determined on a CTCA at 2 years, or obviously signs of or evidence of revascularization within the 2-year primary endpoint time frame. In patients randomized either to the conventional or to the no-touch technique. I think it's interesting, there's still a considerable amount of patients that are not eligible for bi-arterial grafting. The saphenous vein graft is perhaps still one of the most widely used conduits. It's promising. PREVENT-4 was a multi-center trial that already showed that vein grafts tend to become either significantly stenosed or even occlude in 27% of the cases within a time frame of 1 to 2 years. So that's substantial, and I think warrants further optimization of the technique. And by avoiding the graft distension, by avoiding the complete adventitious stripping of the vein graft, one could argue that this technique has the potential to increase graft patency.
You know, I'm wondering whether this still is a timely trial, to be honest. Obviously, you will see bypasses to the circumflex and the right coronary, but not so many to the LAD. Obviously, there we're talking about a lima to the LAD, and that definitely is a superior grafting technique. We have seen multiple trials in the CABG space, if you will, with off-pump, on-pump, minimal invasive or not, radial, the introduction of radial grafts and so on, didn't make a lot of a difference. And in my opinion, it's all about the lima to the LAD, and all the rest, in principle, if it's technically feasible, should be PCI. But okay, that might be a controversial statement, but I don't have that high expectations of this study.
No, I agree with you, but a 27% graft occlusion rate is high. So
but that's what we know, huh?
That's what you know, but that also means there's a lot to gain. So if this works, I think with 1,000 patients, you have the potential to show something.
So you expect spectacular benefits of this no-touch technique?
It could be that there is. I tend to believe that the trial will end up positive, showing a small but statistically significant benefit in terms of the no-touch technique. What that eventually will do to the outcome of the patient is obviously the question, and that's the.
I predict no effect, so we'll see.
Let's see. Yeah. Perhaps more interesting, at least in my perspective, is OCUPI. And OCUPI is a large, again, Korean multi-center randomized controlled trial to assess the superiority of OCT versus angio-guided PCI in patients with complex lesions. So design that, as you know, is perhaps familiar. It's a study that actually focuses on CHIP patients, so patients with complex lesions being either acute MI lesions, CTOs, long lesions, bifurcations, small vessels, Patients presenting with either in-stent restenosis or thrombosis, even vein grafts can be enrolled. So a very broad spectrum of patients, but all patients with lesions with a higher risk of repeat events. So a trial that is substantially powered, 1,600 patients randomized 1-to-1 to either OCT or angio-guided PCI. But interesting, in the OCT arm there is a sub-randomization to either a completely OCT-guided revascularization, meaning both pre and post PCI OCT, as well as a second stratum in which the OCT is only used post PCI in order to assess stent deposition, stent expansion, edge disease, and potential room for optimization. So that, I think, is a second question that the trial will address. Primary endpoint is MACE at 1 year. As mentioned, the trial is somewhat familiar in the sense that it has a design which very much reflects IVUS CHIP and IMPROVE, which are similar trials that are on the way to present their findings with IVUS, also in a similar setting. For sure, this data, to my opinion, will generate a lot of debate, specifically in light of the recent somewhat neutral October trial and the new guidelines for coronary, stable coronary syndromes that will be presented also at this ESC.
But how to define complex lesions? Is it complex from a procedural point of view, or is it complex, as you were alluding to, because of the higher risk for reinterventions or failure, vessel failure? So that I mean is an important driver, because a STEMI or a venous bypass can be complex from the point of view of the need for reinterventions down the stretch, but from a procedural point of view, could be very easy. So I think that, I will be interested to see how many of those relatively easy lesions are being treated in the trial, because the more you move to the real complex lesions in terms of a procedural point of view, then you also will see more and more failures to get your OCT catheter down and to do a proper assessment, because we have been involved in multiple trials even today where we are doing OCT systematically in patients with, for instance, hypercalcific coronary artery disease. And how often do we end up not being able to do a series of OCTs in that same patient? It's not rare.
No, that happens, but I think at the end, I think this is a little bit of two-edged sword. You know, at one time you don't want a trial with only type A lesions and event rates of 3%, because then you need 10,000 patients to power the concept of imaging-guided PCI. So at some point you want to select patients, which is obviously the combination of patient and lesion characteristics that result in higher event rates and a potentially a higher likelihood of showing a, let's say, 10, 20, 30% benefit that you may expect with imaging-guided PCI.
Yeah, but the point that I want to make is that the more complex the lesion is, for instance, the more calcium, the more tortuosity, the lower the likelihood that you will be successful in doing multiple OCT evaluations of that vessel. It becomes very difficult to get your OCT catheter down if there is a lot of tortuosity and a lot of calcium. And it might also be very difficult to have multiple OCTs, because obviously in an ideal world you would like to do an OCT up front and at least at the end of the procedure. Right?
Yeah, we'll see if that is something that pops up in this trial. I don't think in general in lesions like this there will be a big issue, but we'll
see.
See.
So what kind of lesions are they enrolling? If they would only enroll hypercalcific lesions, then I guarantee you.
I agree, but that's not the scope of the trial, right? Let's see. Let's see.
Interesting.
Very good.
Yeah.
REC-CAGEFREE is a second trial that will be presented. This is again an Asian trial, Chinese in this way. It's a large randomized controlled non-inferiority trial of drug-coated balloons versus drug-eluting stents for de novo coronary artery lesions. So I think that's why the trial caught my attention. It's a trial that will randomize 2,270 patients, randomized in 40 Chinese sites to either a DCB or drug-eluting stent strategy. Also, again, quite a broad eligibility spectrum of patients of both those presenting with stable as well as acute coronary syndrome, even including STEMI. So that's quite interesting. Primary endpoint is the device-oriented composite endpoint at 2 years, if I'm correct. So important, this is a large randomized controlled trial in patients with de novo lesions, and that makes it to me interesting because it's one of the first really large trials to assess the concept of DCBs in de novo disease and not just in side branches of bifurcations or in-stent restenosis and so on. So that I think is interesting. Yeah, 2 words of caution, it's a Chinese trial. We know these trials are typically showing relatively low event rates. And also it's a trial with a Chinese technology. I looked what kind of DCB was used, and then it appeared to be a paclitaxel-coated balloon. Shanghai technology called the SWITE paclitaxel-coated balloon. It's a technology, as far as I know, is not available in Europe. But I think conceptually a trial that will show some interesting findings.
A lot to do about drug-coated balloons these days, and people are considering drug-coated balloons for all comers and so on. I think it's very important to note here that there is an important case-based selection here. Non-complex coronary lesions.
It's a relatively broad patient population. What is non-complex? I mean, stable, unstable, bifurcations, we'll see.
But also, you know, if you have a proximal LAD, and a simple LAD lesion, proximal LAD, it's quite a big step for me to move away from a drug-eluting stent.
But that's why I think it's interesting. I totally agree, and I also have conceptually a problem with that, but yeah, we'll see. We'll see. I think that's why the trials to me are interesting. It's, you need to prove the gut feeling that this doesn't feel right, and there will not just be small diagonals included in this trial, so we'll see. Señorita, so we go to the elderly. So this is a trial, Señorita, a multicenter randomized controlled trial sponsored by the NHS, so as such conducted in the UK and Scotland, designed to compare an invasive versus a conservative strategy in elderly patients defined as those of 75 years and older presenting with non-STEMI. It's a trial that were randomized over 1,500 patients with a clinical primary endpoint as well as quality of life. To see what would actually still make sense to do a early invasive strategy in elderly patients presenting with non-STEMI. So quite a provocative concept, but not a new concept. This is a concept that was tested already in 2016 in the After 80 trial in the Lancet that actually showed a 50% lower event rate if you go for early invasive. It was confirmed in the Senior and STEMI trial, also sponsored by the NHS, published in Lancet 2020, again showing the same thing, so a significant benefit of early revascularization. But those studies were open label, propensity matched, so not really proper randomized controlled trials, and that makes this trial different. But honestly, I do not expect any different findings.
Well, you know, I think patients above 75 years old, it's a population that I no longer consider to be very old, right?
Correct.
I think above 90 would be a different story, maybe above 85, but these days, 75 years old in 2024,
there's huge, as you say, there's huge heterogeneity in the type of patients, and age is usually no longer the determining factor. I totally agree.
All right.
Alrighty, finally more on elderly is EARTH-STEMI. So EARTH-STEMI is a meta-analysis actually. It's not a prospective randomized controlled trial that we typically expect in the hotlines, but this is a meta-analysis performed under the leadership of Gianluca Campo from Ferrara, who pooled data of all the trials that we performed to compare complete versus stage or incomplete revasc in patients presenting with STEMI. So FIRE, ComparaQ, Dynamic Pramulti, Culprit, Complete. Pooled all those patient level data, so that's interesting. So it should be patient level data as far as I understood, to address whether the benefit of complete revasc also pertains to elderly patients. So those with 75 years of age and older. I would comment and argue the same as for the previous trial. I cannot envisage having seen any heterogeneity in the treatment effect in any of these previous trials with age. I don't think that this meta-analysis will now tell us that it doesn't make sense to do complete revasc if somebody is 75 or older, but we'll see.
Yeah. It's somewhat different from the previous trial, obviously. I think nobody will doubt that you need to treat a culprit lesion, right? And in the previous study, they were also arguing in a non-STEMI patient where there is also a culprit,
Yeah.
stay away from the little culprit. No, that's a different story. So I think you always need to treat the culprit lesion regardless of the age of the patient. Whether complete revascularization in elderly patients makes the same difference than in younger patients, I think that's an interesting question. So a good meta-analysis to look out for.
It's interesting material. Two concerns from my side. One is the fact that the designs of the study, as you know, are not really properly comparable. One uses FFR, the other doesn't use FFR. One does planned stage revasc, the other says, okay, you go home and we'll see. So I think the control arm is quite heterogeneous. And the second thing is that the benefit, if you will, to support the concept that this complete revascularization approach is better in younger patients, should translate into an outcome benefit over the long run. And most of these trials don't have 5-year follow-up. So we'll see what is included, and we'll see what to digest in the wrap-up.
Yeah. Okay, we go back to the structural space, and we have 3 more TAVI studies. The first one is the popular PAUSE. This was another trial from Joost and his group in Mieghem, a multi-center study including 858 patients with atrial fibrillation on a NOAC or OAC undergoing TAVI. And here the question is, what do you need to do with these patients? Do you need to interrupt their anticoagulant drug therapy, or can you just continue and do the TAVI without patients interrupting their therapy? I think this is a very timely topic. This is very relevant. We already know from the EP space that interruption is not necessary for a safe procedure in terms of pulmonary vein isolation, for instance. But how would that translate if you start using large bore catheters in the femoral artery? So both transfemoral and transaxillary transsubclavian access is allowed. Patients are randomized in Belgium, Netherlands, Denmark, Italy, and Ireland. And then you have a one-to-one randomization to either interruption of the oral anticoagulant drug therapy or the continuation. The primary endpoint is a composite of cardiovascular death, stroke, myocardial infarction, major vascular complications, and any clinically significant bleeding according to the VARC-3 criteria. So again, a timely topic. We'll see whether it's going to be a practice-changing trial. Maybe not, but it definitely is a relevant study.
Yeah, absolutely. And I think it attests to the design led under the leadership of Joost. All of these trials, starting with Popular, have been blockbusters in a lot of the recent meetings. A lot of relevant questions being addressed, and this
very
is
practical
and very practical, pragmatic designs. And
kudos.
Let's see. Absolutely.
Okay, then Notion 3. Notion 3 is then the third in the Notion family of trials in TAVI, and as you recall, Notion 1 and 2 were the first 2 randomized trials that were focusing on low-risk or all-comer patients. Well, Notion 3 is the same thing, all-comer patients undergoing TAVI, but also patients with coronary artery disease. And the question here is, do you need to treat single or multivessel coronary artery disease when you are treating a patient for aortic stenosis? So patients are 454 patients with significant coronary artery disease are randomized 1-to-1 to either TAVI plus PCI or TAVI without PCI. We already have a randomized controlled study on this topic. This was the activation trial in the UK. Only 235 patients were enrolled in that study. And I think the main caveat there was that the mean age of the patients was 83 years old. Well, in that trial, there was no benefit whatsoever of proceeding with a PCI procedure. As a matter of fact, it resulted in more bleedings. I think Notion 3 is a little bit of a different scenario. I think we'll see younger patients. But at the same time, this is not a home run for revascularization. So I'm very much looking forward to the outcome of that study. The primary endpoint is all-cause mortality, myocardial infarction, and urgent PCI at 1 year. And I think this is the same comment that Joost already mentioned previously. Maybe 1 year is not the right timing. Maybe you want to look at 5 years to see a more important or significant clinical benefit. But at least an interesting study again to look forward to, but different from previous randomized studies.
Positive?
I think it's going to be a negative study.
I agree. I totally agree. And the reason is that it's a 1-year follow-up. These are not ACS lesions.
That's it. That's essential.
Stable coronary artery disease. And these patients will have their TAVI and then feel better.
Exactly.
Per definition. So they will feel better.
Yeah.
And they say, oh, wow, now I can climb stairs again. And who cares about this 50% lesion that will be randomized in the concept of this trial with the FFR of 0.80?
Yeah. But some may argue, okay, now the patient has the valve replaced or treated and now becomes more active and now
starts to become symptomatic.
So we'll see. It's an interesting study and I think definitely an important one.
Yeah. The only problem here is it's open label, right? So if you want to properly test the concept
and small sample size.
And small sample size.
That's I think also a consistent feature in the Notion families, small sample size trials. Yeah. All right, then the last trial is the REA trial. This is a randomized controlled study focusing on women with symptomatic severe aortic stenosis, and this all-comer study, as far as women is concerned, will randomize patients 1-to-1 to TAVI or surgery to treat their symptomatic severe aortic stenosis. The TAVI platform to be used is the SAPIEN valve, and it is compared to any commercially available surgical bioprosthesis. The composite primary endpoint is all-cause death, stroke, and rehospitalization. Very familiar with that endpoint from the low-risk trials. Well, honestly, I'm a little bit critical for this kind of trials because women are not underrepresented in the TAVI space. You know, all the randomized controlled studies have approximately 50% split between men and women. As a matter of fact, the latest trial, the SMART trial, had at 87% of women, only 13% of men. So I think at one point I understand the diversity and the importance of also generating sufficient research in men and in women, but whether this really is needed in this area, I'm not so sure. But again, I expect a massively positive trial because if anything from previous randomized controlled studies, we already know that TAVI is maybe even more effective in women than in men. Yeah, nothing new, I think.
No comments with respect to this trial.
With that, I think we're coming to the end of our preview of the ESC 2024. Again, something to look forward to, and we will be wrapping up this trial at the end of the month. Thank you for staying with us.
Thank you. Bye-bye.
Goodbye.